So let's go ahead and get started. I want to be respectful of everybody's time. I'm sure that some other reporters are going to trickle in. Welcome to today's briefing on the subject of healthcare consolidation. I'd like to thank our partners Health Affairs and the JKTG Foundation for their support of this briefing. And I'm actually going to turn it over to Alan Weil, who is the editor of Health Affairs, to get us started.
Thank you, Marilyn. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're really happy to have you here. It's a great pleasure to have a panel full of lawyers. We don't get to do that very often, so it's a particular joy. I'm just going to give literally a 2-minute introduction to the topic so that we're clear how important this morning's conversation is for healthcare. A consistent theme in healthcare right now is consolidation, but there are there's tremendous variability in how that's playing out in different parts of the healthcare sector. We have consolidation within the healthcare provider community, both horizontally and vertically. We have hospitals and physician practices merging and consolidating. We also have it vertically with alignment between hospitals, physicians, home health agencies, and the like. We have consolidation going on in the pharmaceutical industry. We have consolidation going on in the insurance industry. So at one level, you'd think, well, this is all consolidation, and we just need to figure out whether that's a good or a bad thing. But it turns out that the rationale offered for these different sectors is quite variable. In the horizontal mergers are really designed purportedly to build efficiencies and to improve information flow within sectors. Similarly, vertically, we're changing payment models, and that suggests the need for alignment between hospitals, physicians, and other healthcare providers to provide more continuity of care. In the pharmacy space, in addition to the tax issues, which I don't know that we'll get into today, having to do with international borders, there's the high cost of drug discovery and bringing products to market. And in insurance, the rationale is everyone else is doing it, and if we don't do it, we can't negotiate effectively against a consolidated provider system. So consistent theme of consolidation, but tremendous variability in the rationales offered. At Health Affairs, we publish a lot that's relevant, but it turns out that the legal structure and the evidence base for whether these mergers are a good or bad thing ultimately for consumers is pretty thin. The legal structure really comes out of an industrial era, and the economic analysis doesn't primarily around consolidation doesn't primarily come out of healthcare, and it certainly doesn't primarily come out of insurance. And those the changes going on in those two fields are an important backdrop. So we've got a lot to cover, and I'll turn it back to Marilyn to introduce those our speakers this morning.
Fantastic. Thank you, Alan. The one thing I wanted to point out in your packets is that you do have a piece that comes from the LA Times on inversions. And we are not going to focus so much on inversions today, although, of course, we are going to focus, we are going to talk quite a bit about pharmaceutical industry consolidation. But the reason that we put this piece in here, even though we're not going to get much into it today, is that there is legislative activity brewing in this area. If you're not familiar with inversions, these are deals that involve foreign companies and moving headquarters overseas with the purpose of avoiding taxes or lowering taxes. So you do have a piece in here about this, and there could be legislation, we understand, coming up as early as January or February. So with that, let me introduce our speakers today. On the other side of Alan, we have Debbie Feinstein. She's Director of the Bureau of Competition at the Federal Trade Commission. She has also been a partner at Arnold and Porter, working in their or heading their U.S. antitrust practice group. You have full bios in your packet, so I'm just going to give you the highlights here. And on Debbie's other side is George Slover. He's Senior Policy Counsel at Consumers Union. He has served in all three branches of the government here, including the House Judiciary Committee, the House Energy and Commerce Committee, and the Department of Justice. in their antitrust division. And to my left is Andrea Marino. She's a partner and co-chair of Goodwin Procter's antitrust practice. Like all of our panelists today, she has done double duty or triple duty, and she's been at the FTC, she's been at the Department of Justice. So we have a really exciting panel today. So I'm going to turn it over to each of them to give us some introductory remarks, and then we'll open it up for your questions. So I'm going to turn it first to Debbie.
Great. Well, thanks. It's really a pleasure to be here. I have to start with the usual caveat that my views are my own and not necessarily those of the Commission or any individual commissioner. I want to talk to you briefly, because I'm interested in your questions about what you want to hear about a couple of areas. I want to start with a couple of overview points. First, the Federal Trade Commission and the Department of Justice Antitrust Division share jurisdiction in the antitrust area, and typically the FTC does provider side transactions, so hospitals and pharmaceuticals. The Department of Justice looks at insurance mergers. So I'm not going to be able to talk with any specificity about the insurance mergers because that's what DOJ covers. I can talk to you about general types of arguments and how they might be addressed if they're not specific to particular mergers. Second thing I want to make clear, because I think it's very different than a number of the industries that agencies that you all cover, is we are not a regulatory body. We get called the regulators all the time. We're not. We're law enforcement agency. And the reason that matters is we can't simply decree things. We can't simply say, this is legal, this is not legal, here's the framework that you have to apply, or you violated our rule. We have to go to court if we want to challenge a transaction or a practice, either federal court or our own administrative court. So that's just, you have to bear that in mind when you're thinking about what it is that we do. I want to talk about a couple of areas that we've been focusing on lately. One is hospital mergers. Primarily, our focus has been on horizontal combinations. Hospitals that are competing with each other, competing both to negotiate with insurance companies and competing to actually get patients in the door in the same geographic area. There are hundreds of these transactions a year. We challenge a handful of them when we find that they're problematic. A little history is important. Hospital mergers and the FTC's concern about them is not something new. This has been going on for decades. And candidly, the FTC was on a bit of a losing streak in the 90s. And so they sort of sat back and regrouped and took a really hard look at what they were doing and why the agency was finding that these deals were problematic, but the courts were not finding it. And so the Bureau of Economics did a number of retrospective studies. They looked at transactions that had gone through that we thought might be problematic, and lo and behold, found that there was quite clear evidence that these were, in fact, increasing prices. They used that to develop better models to determine the likelihood that a transaction would increase prices and use that as a way to start explaining the story. And lately, the government's been on more of a winning streak when it's come to hospital mergers, and we're continuing to bring challenges. We brought one about a month ago to a combination of West Virginia hospitals, and last week we brought a challenge to a combination of Pennsylvania hospitals. I should note that our analysis does take into account things like quality and cost savings and other benefits. We take very seriously a couple of things. One, whether a company is failing. If there are hospitals that are in fact are about to go bankrupt and are about to close their doors, acquisition by a nearby competitor is better than the hospital simply closing the door. And so that is something that we take into account. We look at the quality implications. If we were to see actual evidence that a transaction would increase quality, even if it meant a little bit of a price increase, because that would be a quality adjusted neutral, right? If you pay $5 for something that's this good, but you pay $10 for something that's twice as good, that's not necessarily viewed as a price increase, because when you look at the quality adjustment, it might not be so problematic. That might be on balance good for consumers. We haven't seen that case. We haven't seen the case where the transaction is otherwise anti-competitive, but the quality outweighs the competitive concerns, but it's something that we're alert to. Finally, something to note on hospital mergers is we frequently hear that there is a conflict between the Affordable Care Act and antitrust enforcement. It might be the question I have gotten most in the 2.5 years of this job isn't there a conflict between the antitrust laws and the ACA? And I would say an emphatic no. If you look at the ACA, it specifically says it's not meant to supplant competition, and we think that it is quite clear that the goals of the ACA and antitrust are in harmony, not in conflict. What we often find is that there are other practical ways of achieving coordinated care and alternative payment models beyond merging with a close competitor. The final thing to say is often when we do find a problem, the remedy in most transactions outside the hospital area are divestitures. Good example, grocery stores. You have 2 nearby grocery stores in a market. The solution is one of the grocery stores gets sold to somebody else. Competition is restored. Often in hospital mergers, we get promises that are proffered to us from the hospitals that they will simply agree to price caps, agree not to change their behavior, agree to increase prices only at the rate of inflation. Those are not remedies that the FTC finds acceptable for a couple of reasons. One, we can't guess what the right price is. Prices may go up, prices may go down. Second, the literature makes quite clear that when you put a price cap on something, the quality diminishes, and there's no way to basically make people promise to increase quality, to innovate as much as they otherwise would. And so we find these sort of conduct remedies problematic. And I think that's why you see more than the usual number of hospital merger cases get litigated, because often they're 2 hospital combinations. There is no divestiture that will work because that would undo the deal entirely, and that's why I think you sometimes see litigation there. We do look, all the things that I've said about hospital mergers really apply to other provider mergers. We've brought cases against outpatient clinic combinations. We've brought challenges against combinations of physician practice groups as well. We've looked at, not yet brought a case, vertical transactions. When a hospital acquires a physician group, it's an issue that could be problematic, but it depends on the facts, and that's not a case that we've brought yet. Let me turn, there's lots more to talk about, but I want to make sure we all have time for questions and the like. Let me turn for a minute to pharmaceutical transactions. At one level it's interesting because the pharmaceutical arena is really quite fragmented in the sense that there are literally dozens upon dozens upon dozens of companies that do pharmaceuticals. What we look at is pretty narrowly the combination of particular products for particular end uses. We go so narrow as to determine whether or not they're the same mechanism of action. What we've also found through our investigations is that while the combination of a brand and the first generic company can affect prices, because when a generic comes in, it lowers the price, that when the second generic comes in, the brand sort of becomes somewhat irrelevant to the competition, and you can have a market that just consists of the 2 generic products. And so a merger of 2 generics can be anti-competitive even if the brand is still out there, and that's true of the 3rd and the 4th and the 5th generic. There's been a lot of empirical research that says at least up to 4 or 5 generics, the entry of each new one actually decreases price, and that's the reason that we're worried about the combination of both brand generic, and generic. This has been a constant area of enforcement. In the past decade, we've probably done several dozen consents, which have led to the divestiture of hundreds of products. We're seeing particularly large deals now, I think, because of the incentives with the tax inversion laws. And so we're seeing the really large transactions like the Pfizer Allergan, the Teva Allergan, the Mylan Perrigo, Teva Mylan spat, much of which was caused by the inversion tax laws. So we think we will continue to see these. For the most part, these transactions end up being allowed to proceed with divestitures. When we require divestitures, we require pretty fulsome divestitures. We want to make sure that everything that the buyer needs to continue to manufacture, sell, develop the product are part of the package. We typically require that there be a monitor. It's chosen by the companies involved. We approve the monitor. They pay for the monitor, but the monitor reports directly to us, not to them, to ensure that the commitments that they've made are carried out, and they're usually specialists in the area. We don't use these just in pharmaceuticals, but they've been particularly prevalent in pharmaceuticals. We always require an upfront buyer. We want to know who the buyer is going to be, and we want to make sure that they have the capabilities to continue. We're currently undertaking a remedy study to determine whether all of our consents are effective, and including that is a substantial component that's going to look at the pharma area consents. One final area that I want to mention is high drug prices. We get asked a lot, what can the FTC do about high prescription drug prices? Again, a couple of things to note. We are not a regulatory body. We can't simply put a cap on prices, even if that were a good idea, which I think there's a lot of questions about whether or not that would be workable and whether or not it might reduce innovation. There'd have to be a lot of thought about that. That is not something we can do. We can only bring actions under the antitrust laws. And so it is not illegal to have a monopoly. If you developed the better mousetrap, if you developed the better pharmaceutical product and you have patent rights to that, you get a monopoly. And simply exercising that monopoly by charging a high price is not against the antitrust laws. Now, if you use that monopoly and do something that is exclusionary, for instance, you entered into an agreement with all of the only suppliers for a particular pharmaceutical ingredient, that might be an act of monopolization that is anti-competitive. If you enter into an illegal agreement, a price-fixing agreement, an exclusive dealing agreement, again, that might be illegal, and we certainly, our reverse patent settlement pay-for-delay cases are an example of an agreement between competitors that may lead to higher prices that is anti-competitive. But sometimes the high drug prices, and we look at them often, simply come about because a new owner had a different strategy and decided to increase the prices as much as it could, and by itself, if the companies didn't have competing products and it's literally just a change of ownership and a different philosophy, that is not typically something that we can do anything about because it is not an antitrust violation. But we do look every time we see this to see why it is that the prices have increased in the hopes that there might be something that we can do. So I think that's sort of an overview of some of the key things we're doing, and I'll turn it over to our next speaker.
Great, thanks. So let's switch over to this side to Andrea.
Thank you so much, Marilyn, and thank you for having me here today. It's a real pleasure. I am in private practice, although I've spent my entire career doing antitrust, and I listen very intently anytime Debbie speaks because it's her advice that I end up having to consider and give back to my clients. So this is just as informative for me as it is for all of you hearing her thoughts. Now, that said, I think I have a slightly different take on some of her comments. So I'm going to talk about sort of I'll talk about the insurance markets, I'll talk about provider and hospital consolidation, and then lastly, just get onto the topic of pharma as well. In terms of the insurance markets, I'm not involved in any of these transactions, but the thing I'm most interested in seeing how DOJ, pardon me, how DOJ undertakes this investigation is their concept of a national market and their concept of leverage. Bill Bayer, who's in charge of the antitrust division, a former partner of Debbie, somebody very well known to the antitrust community, has given speeches not about healthcare, but about other kinds of industries, where he's noted his concerns about what is leverage, what is having national power. And although healthcare antitrust analysis has some very distinct and discrete aspects that are completely different from other kinds of industries. I think it's important to remember that that's his view, that's his policy, if that's his bent, then I think you can expect that to carry over at least a little bit into his review of the insurance markets and into what DOJ is doing. So as I think about those two pending very large insurance mergers, the thing that occurs to me is that these are very well-counseled, very sophisticated entities, and that the analysis and that the investigation is likely to be very heavy on economics and very heavy on what we might consider natural experiments. So that is, they're going to try and convince DOJ that they believe this is what will happen if these mergers are allowed to go through. Now, merger enforcement is predictive entirely in nature. You look at what the statute is, it's absolutely prospective. And so the economists are going to have the challenge of, the private party economists will have the challenge of convincing the government that they believe prices, quality, all of the things antitrust concerns itself with prices will be reduced, but quality will not be reduced. So I assume this investigation is proceeding as a very data-heavy exercise. The other thing that I think you see a lot of in the press, the CEOs and the other leaders of these organizations are talking about how there's not much geographic overlap, that in certain regions they don't even compete against each other. And that could very well be true. But again, going back to sort of this view of national markets, you saw it in AT&T T-Mobile several years ago when the DOJ challenged it. Again, that's not a healthcare deal, but I think it's still illustrative. There, the DOJ said, we think that we should not be reducing the number of national providers, even though on a regional level you may have had additional choices. You saw it very recently, just last week, when the FTC challenged the Staples Office Depot deal. You saw it earlier this year when the FTC challenged the Cisco U.S. Foods transaction. The concept of a national market and having national power, I think, is going to be, again, another challenge for these insurers to have to overcome. And then you move to the remedy. Obviously, Debbie described in pharma markets how remedies are very much viable, very much a live solution to antitrust overlaps. The difficulty here is, to whom will these insurance companies divest the covered lives? You have unprecedented consolidation. You basically have 4 of the big 5 are involved in these deals. And so who is going to be able to step into the shoes of the lost competitive entity and restore that competitive balance? So I think it's going to be very interesting to see the way in which this investigation unfolds and what DOJ decides to do. I make no predictions about which way it will come out. What I can tell you is I think that if it comes out, if the deal gets cleared, that there'll be some very robust remedies attached to it on a very regional level. And if the deal gets challenged, it's very likely to be because of this national leverage problem. On the issue of provider and hospital mergers, again, my bias is to try and figure out a way to get my clients' deals through the FTC and the DOJ. And so, I very much need to know, keep my finger on the pulse of what it is that both the FTC and DOJ are valuing. And the one thing that I have heard probably every time Debbie has said it is that there is no tension between the Accountable Care Act and the antitrust laws. The difficulty is when I talk with my clients, some of whom are very small, and they say, we don't have a choice. There's no way for us to be able to accomplish, get the benefits of collaboration without the full-on merger. And that may be unique to the quirky set of clients I happen to work on behalf of. It may be symptomatic of something larger, but I do think there's a tension between the ACA, which values collaboration, and the antitrust laws, which sometimes think that collaboration can lead to improper consolidation. So that's just a challenge that's there. And I think it's something you'll continue to see. And I think that's why you do have many in the healthcare side and on the provider side. You do see a lot of these challenges actually moving along into court. A lot of these, over the past maybe 10 years, there's a lot of deals that get abandoned, but I think you see on a very consistent basis, the FTC is going into court. Debbie mentioned the Hershey case that they just filed, Hershey, Pennsylvania. There's also a case in Huntington, West Virginia that's ongoing. Those are very interesting, and I think you'll continue to see that tension play out between the ACA and the antitrust laws. Now, the thing I think that will be that I absolutely tell all of my clients is if you're going to be interested in doing any kind of consolidation, the remedy must be structural. I think this is a bright line rule that I can actually, very little of what I tell my clients I can say with confidence, 100% confidence, but this is one area where I tell them, if you're preparing to go forward, a structural remedy is going to be absolutely necessary. And it's for all the reasons that you heard earlier, because these conduct remedies, where you just try and regulate someone's behavior as opposed to fundamentally altering the backbone of the economics behind a transaction, they just aren't as effective. And the economics and the data and academic studies have borne that out. So you really need to be on the lookout for that. Now, an interesting quirk here is that very occasionally, and with some increasing regularity, you see state attorneys generals who are willing to allow these transactions to go through with conduct remedies, whereas you have federal enforcers who may not share that view. The West Virginia case I mentioned, which I think it's Cable, Cabell, I think it's pronounced Cable, and St. Mary's in Huntington. There, the Attorney General actually signed an agreement blessing the transaction, and the parties agreed to many of the same kinds of conduct remedies Debbie described earlier. And the FTC there chose to challenge it even in the face of that Attorney General approving the deal. Now, from my perspective, and I've been doing this a while, but not forever, my perspective, that's unusual. Usually you see great unity between what the FTC and the state attorneys generals do. You look at, and same thing on the DOJ side, you look at any of the complaints that they bring, and the first page will often take you, just the caption on the first page takes you 2 or 3 pages because they have all the names of the state attorneys general. So very interesting to see the FTC depart there. Another interesting development, which is now about a year old, was in Massachusetts. The Boston area healthcare market, which is obviously a preeminent research center, a big focal point in the world of medical research. Partners, which is the entity that owns all of the hospitals you've heard of up there, Brigham and Women's, Mass General, tried to buy South Shore Hospital and Hallmark Health System. And there again, the Massachusetts Attorney General came up with a consent decree that focused on conduct remedies. A group of private parties, and I was involved in this, representing the private parties, decided to challenge the Attorney General's consent agreement. And ultimately, before a state court judge, the state court judge refused to enter the consent decree and said that what the conduct remedies would do would basically put a Band-Aid on a gushing wound. So there's some interesting dynamics at play in healthcare markets you don't always see in other industries. What I tell my clients is that when you're thinking about moving forward with one of these deals, the very first thing we have to do is look at what is going to happen to quality, what does the economic evidence say. So whereas some other transactions pop up on my desk, we kind of get started from there, they'll sign the agreement, we'll move forward. I think in these provider and hospital deals, you really need to be prepared to do a lot of work on the front end, because this is such an active enforcement environment that what you would hate to see is for the parties to invest time, resources, money, and then ultimately find themselves in the midst of a challenge. So it is incredibly important to start working early. On the pharma side, I actually think that I agree completely, and my experience is consistent with everything Debbie said. I think there's been very good consistency at the FTC over the past 20 years in terms of how they look at pharma mergers. And I think because of that consistency, there's real predictability. And so I do also do work on behalf of pharma clients, usually smaller ones, that are being acquired by some of these bigger ones. And so there too, I think you can draw some fairly bright lines about what's going to be permissible and what's not going to be permissible. As long as a remedy is available to a competitor that will be able to step into the shoes immediately of the entity that's lost, I think the FTC generally believes that pharma divestitures can be very successful. And so I would expect to see, things to continue at the same rigor, same pace that what you're seeing now, as long as you keep that number of pharma competitors at a sufficiently high level. And I think certainly right now there are plenty of very large players and plenty of mid and small players who really can keep competitive dynamics at the point where they need to be.
Great, thank you, Andrea. So let's turn now to George for the consumer perspective.
So a good way to start thinking about the consumer perspective is that consumers want meaningful choice. When we have options, companies are spurred to compete for our interest and our loyalty, and that leads to better quality and better affordability. We don't necessarily want the most choices, we want the best choices, but that depends on keeping the marketplace open for creating meaningful choice. Not just choice being available today or tomorrow or the next year, but over the long term, keeping the market open to choice. That's how we get new thinking and best choices in the future. And for consumers to get that meaningful choice, there needs to be enough competition at every level of the supply chain so that everyone has meaningful choice. The antitrust laws properly focus on us consumers, but we're affected by what happens in the rest of the marketplace. The supply chain in healthcare is a bit different. There's the additional complicating factor that most consumers encounter. The cost of healthcare is filtered through their insurance company. That's not as unique to healthcare as some suggest, but it's important and it affects the whole picture. So both the insurers and the providers claim to be in the consumer's corner, and each says we need to be strong to protect you. The providers say we want to bring our best professional judgment to bear on giving you the care you need, and we can't have insurance companies interfering with our professional judgment. And insurers say providers have no restraint on what they charge except the restraints we put on them. We're the ones who bring the costs down. And both are right to a point. But if either of them gets too much leverage over the other, what the antitrust laws call market power, then consumer choice gets restricted and quality, value, and innovation all suffer. So what we need is competition and the meaningful choice it translates into on all levels. Providers need enough insurers who provide access to patients, and insurers need enough providers who provide health care. Each needs to have alternatives somewhere else to go so that neither can dictate terms. If a hospital network or group medical practice or drug maker or medical device manufacturer is powerful enough that an insurer can't afford not to contract with it, it can jack up its prices. And if an insurer is powerful enough that a hospital network or group medical practice or drug or device maker can't afford not to contract with it, it can force prices down so far that quality of care is jeopardized and innovation. We want doctors, hospitals, clinics, drug and device makers motivated to look for ways to lower prices without cutting corners on quality of care and other aspects of service excuse me, that consumers value. That's the difference between providers wanting to trim costs to compete as one aspect of their efforts, thank you, versus being forced to cut service to the bone in hopes to survive. It's the difference between responding to incentives that flow from competition versus knuckling under to a market dictator. Similarly, we want insurers motivated to look for the best provider networks without being forced to contract with a network charging exorbitant rates just because it can in order to give policyholders access to the health care they need. The merging companies in healthcare or in any industry aren't necessarily aiming to reduce competition. Getting bigger and stronger can be a natural response to pursuing business opportunities in a changing marketplace. Changes in technology and in the marketplace and in consumer choices and in the law create opportunities and also uncertainties, and companies react by looking to make sure they are positioned to move ahead successfully. Part of that is making sure you have reliable sources for the inputs and partners you need to provide the products and services that consumers want to buy, and that you have reliable and effective ways to reach your consumers. And it can help to be big enough so that you know suppliers and partners and purchasers will see you as reliable yourself. We get that, and so do the antitrust laws. Similarly, it's okay to find ways to get ahead of your competitors so that you're the preferable choice. If that spurs you to make your products and services as high quality and as low cost as you can, because that's also good for consumers. But if it spurs you to look for ways to limit the competition you have to worry about, that can be harmful. Smoking gun memos or board presentations that vow to crush the competition can be colorful evidence, but the focus in a merger investigation is not on the intent, but on the likely effect. The vast majority of mergers and integrations don't approach the levels of market concentration that threaten competition and consumer choice. But when they do approach those levels, they need to be looked at carefully, and when they cross the line, they need to be fixed or stopped. And figuring out where that line is and how close it is to being crossed can require extensive investigation and analysis, which is why we're thankful we have the Federal Trade Commission and the Antitrust Division. Companies seeking to justify a merger often have a checklist. They say the merger will create cost-saving efficiencies or synergies. They say other companies will enter the market and maintain the existing level of competition. And they say that if there's a concern in this or that specific local area or product or service offering, that can be fixed by selling off, divesting just that one part of one or the other merging company to some other company who will take it over. But all of these justifications have their shortcomings and caveats and need to be carefully examined. And I think enough has already been said about the conduct remedies and trying to enforce that kind of promise. I won't go into that. But for these three that I did mention, the efficiencies aren't even relevant until the merger takes market concentration past the threshold of concern and there's an antitrust issue in the first place. But once you are beyond that threshold, the efficiencies have to be enough to actually prevent any net harm to consumers. And for the longer term, they have to prove that the drive to innovate is not going to be compromised. It's not a question of a balancing test that you're going to allow some harm to competition as a trade-off for some other supposed benefit. And remember that competition inherently involves duplication. So if you're talking about the efficiencies as being, well, now there's two accounting departments or two distribution systems, and now we'll only have to pay for one, and so we're going to save a lot of money. You don't have competition unless you have duplication in all of those aspects, and so you can provide that meaningful choice. So an argument for eliminating those kinds of or eliminating those kinds of costs is really an argument for allowing a monopoly. So we don't want to go there. The other question about the efficiencies, if they're like synergies, you know, we can get the best of both companies and all of their knowledge and expertise. You don't always have to acquire an entire company in order to get that expertise. You can hire, not acquire. And that's often a way to better preserve the competition. So the so-called efficiencies have to be dependent on the merger and not obtainable some other way that's safer for competition. So the promise of other companies ready to enter the market and compete, either on their own or with the help of a divestiture handoff, also needs a reality check. If these companies are ready and willing to compete, why aren't they doing so already? And how do we know that they are up to the challenge and are in for the long haul? Now that's something that, as Debbie says, the Federal Trade Commission looks at carefully and assures itself that that is going to be the case. But it's always going to be a roll of the dice with new entry. You just never know for sure. Often they don't work out. And often the most effective competitors are the ones who are already competing. Furthermore, we don't want concentration allowed to increase right up to the very brink of where the harm to competition is obvious and immediate. Then there's no margin for error or for all too foreseeable developments beyond the control of the antitrust laws or anyone else. What if one of the current key players you're depending on later decides to downsize or close shop? The antitrust laws don't force someone to work, and they don't force a company to stay in business. It's also important to look not just at a snapshot of where competition is happening now and what current competition a merger would immediately eliminate, but also to look over the next hill at what the merger means for future competition. A consummated merger can't be easily unwound to restore lost competition. The antitrust laws recognize the importance of taking potential competition and market uncertainties into account. The Clayton Act is written to prohibit mergers that may substantially lessen competition or tend to create a monopoly, which gives plenty of latitude for taking the longer view. We're encouraging the Justice Department to take a careful look at the pending Anthem Cigna and Aetna Humana health insurance mergers, which combine the largest 4 health insurance companies, spanning numerous product sectors, I should say 4 of the largest 5 health insurance companies, spanning numerous market sectors in numerous states and local areas. They are already in various degrees of direct competition with each other and are in prime position to expand further and into new territories. They would seem to already be as big as they need to be to make a go of it on their own without joining forces with their most able competitors. Earlier this year, we encouraged the FTC to take a hard look at the proposed Teva-Mylan merger, a hostile takeover that would have combined the 2 largest generic drug makers in their vast generic and specialty drug portfolios. Teva abandoned its takeover efforts in the face of FTC concern. The healthcare marketplace is complex in how it operates and how it motivates providers, insurers, and consumers. A regulatory framework has developed over many years and is still evolving to work within that and shape that complex environment and to help safeguard consumers, help keep costs under control, and help make a full range of healthcare products and services available. But even the best regulatory framework works better where competition within appropriate regulatory limits gives businesses an additional incentive to want to improve service while holding down prices and providing better value. Regulation and competition both work best when they work hand in hand.
Great, thank you. So we're going to open up for Q&A right now. We are videotaping, by the way. This videotape and a transcript will appear on the AHCJ, the Association of Healthcare Journalists website, as well as on Health Affairs and the Alliance for Health Reform. So we have a couple of roving mics. So can someone hand Chris Fleming a microphone, please?
Hi, thank you guys. These were great presentations.
And if you could introduce yourself, please.
Oh, sorry.
Even though I just named you.
Chris Fleming from Health Affairs blog. I wanted to pick up on a theme that came up in Deborah's and then in Andrea's presentations. The idea, Deborah, you said that there was no conflict between antitrust and the ACA. Andrea, you seemed to suggest that some of your clients, particularly the smaller ones, felt that there was. I wonder what Deborah's reaction would be to what Andrea said, and then also, Andrea, your reaction to Deborah's point that she made that there are ways short of full-scale merger to achieve the kinds of ACA goals, coordinated care, better quality that providers can take that will not be as harmful to competition.
Sure, thanks. So a couple of points. First, just the empirical. There are hundreds of ACOs. ACOs are all collaborations among different folks. Sometimes they involve hospitals, sometimes they involve hospitals and physicians. They scan the universe. Hundreds of ACOs. How many have been challenged by the antitrust authorities? Right, 0, not 1. That suggests that there are, in fact, ways for folks to collaborate. So that's sort of point 1, is that folks are finding a way to do it that do not run afoul of the antitrust laws, and I think that's really important. The second thing is to talk about the distinction between collaboration, even among competitors, and something that leads to increased consolidation. And the example I always use, and it might be showing my age, but I remember as a kid the Incredible Edible Egg campaign, right? Remember that? The advertisement, it's sort of like the, Got Milk campaign, right? This was a group of competitors. The egg manufacturers all got together and said, let's spend some money to promote the health benefits of eggs, that eggs are okay to eat. That was a situation where they collaborated on delivering a message to consumers. They did not simultaneously, however, fix the price of eggs, as far as we know. That's the difference between collaboration and consolidation, and I think it's important to bear in mind. We often hear things like, well, to do population health management, you really need data on a larger population than maybe that's covered by one hospital. Well, you can do that. There's nothing in the antitrust laws that prevents all the hospitals from, in an area, from saying, you know what, it would be great if we all got on the same IT system so that we can share information with the physicians in the area. It's okay if we sit down and have our quality experts sit down and go, what's your rate of MRSA? You know, we're trying to figure out if the rate of MRSA is something endemic to the city and the population that we're in, or something we're doing bad as a hospital or need to be doing better at. You can share that stuff without at the same time having to set the prices together or negotiate together with payers. So there are lots of things that you can do that are collaborative, even with your competitor, even with the hospital next door, that do not involve the kind of consolidation and increased leverage against payers that would increase the price of healthcare.
Well, you know, I don't necessarily disagree with anything you just heard. I mean, for some, the use of ACOs has proven incredibly valuable and very viable, and you see that around the country, and lots of these are springing up. I think you'll continue to see it. But for other entities, their business reality is such that they can't do these high touch areas of collaboration and get the efficiencies they need to bring costs down without having that complete unity of interest and without being able to go negotiate singularly with payers. And I think that the background that's interesting to me here is that you know, we haven't talked too much about how the payers interact with the providers, but for many of the clients I counsel, their greatest fear are those yearly or every other year negotiations they have with the big payers, because those payers say to them, well, your reimbursement rates are going down 10% no matter what. And then for the providers to have to make adjustments and to be able to do the things that they want to do to keep the quality of care up and to keep, you know, their entities functioning in the way that they want while they're being paid less, it's a real challenge. So, you know, Debbie's absolutely correct, and I give this advice all the time. There are tons of things you can do short of a full-on merger, short of sitting and negotiating with these payers, which is the third rail, and frankly, in these provider deals. But it's hard, and it's really hard for these businesses whose on the ground, boots on the ground reality makes it especially challenging.
Can I ask one quick follow-up?
If you get a microphone.
I was just sort of intrigued because people often make the distinction, you know, whether the combination is often presented as a way to increase quality, and then the other side will say, no, it's a way to have market power and increase payment. You seem just now to make the case that, in fact, you can't divide those two, because if you don't have the market power to negotiate effectively with the payers and get better payment, you don't have the resources to increase the quality. So should regulators and law enforcement agencies be looking more favorably on combinations that are partly designed to negotiate, to have more market power to negotiate with the payers?
No, that's not what I was trying to suggest. I mean, you know, for me, the quality argument is largely separate. And to be candid, most hospitals, most providers around the country are pretty good on quality. And so I would never rest my defense on being able to say, well, we're going to see a dramatic increase in quality here. That's not what I was trying to suggest.
If I could make one or two more points, which is, the health insurers care about this stuff as much as anybody else, and we routinely hear from them that a particular merger is completely fine. And an example of that was we looked at a merger of a large academic medical center that was filled to the gills, and it was combining with a small local provider some miles away, I think, but clearly in the same geographic market. And the plan was, you know what, I'm going to take the kind of routine primary care sort of hospital things and move it to this hospital which has excess capacity so that I can keep the beds open for tertiary and quaternary care and that sort of thing. And we talked to the insurers, and the insurers said, yeah, you know what, this is not going to be a problem for us. In fact, it's going to reduce costs for us. And we let that one go. I mean, the insurers have a good sense of, do we think that this is going to increase prices or decrease prices? Do we think that this collaboration is beneficial? If they see something that is going to reduce their cost and improved quality, reduce cost, right? You get people in and out of the hospital, you have fewer readmissions. So the interests can often be quite aligned. And so we do look at the facts of this. And I would note that so far the courts have agreed with us, and the best example of that is the case in Idaho with St. Luke's, where the judge basically said, look, I get what they're doing, and I completely agree with what George said. This is not about bad intent. We sometimes see bad documents, but often we find that, the hospital systems, in fact, want to do this for the right reasons. It's just we don't think it's necessary or sufficient to achieve the goals. And the judge in the St. Luke's case agreed with us that while he had every belief that they were trying to do the right thing with a combination of these physician practice groups, that in fact there were other ways to achieve it. There was evidence that they were already working on many of these things even without the merger, and therefore could accomplish them. And he basically found that he didn't think the ACO conflicted, and he wasn't prepared to do a little healthcare experiment instead of following the antitrust laws that have been around for 100 years and I think have served us quite well.
I would just add briefly that in those negotiations you were referring to, we want the providers to have to negotiate with the insurers, but we also want the insurers to have to negotiate with the providers. And so we want each of them to have effective alternatives so that no one can really lay down a take it or leave it. And so we're concerned about this spiral where the providers are saying the insurers are too powerful, we need to get powerful too, and the insurers are saying the providers are getting more powerful, we need to get more powerful too, and you end up with what has been long referred to in antitrust circles as a sumo wrestler situation, where one says, there's a sumo wrestler over there, put us in to do battle for you against that one. And they end up usually finding that it's in their best interests to accommodate each other in some way, and then the people on the outside end up suffering from that.
Hi, Joyce Frieden from MedPage Today. I was interested, Ms. Feinstein, you said that you did challenge some physician practice mergers, and so I wondered if you could talk a little bit more about, what triggers interest from the FTC in that area, and what you might be looking for, because you said what you haven't done is challenge the hospitals trying to buy the physician practices.
Sure. So the case that we brought is the St. Luke's case in Nampa, Idaho, and it combined the two largest physician practice groups in Idaho. People sometimes refer to that as a hospital-physician merger because St. Luke's was a hospital that had a physician group. What we challenged was the horizontal combination between the two physician groups, not the vertical part of the transaction, which I'll get to in a minute. We can hear about it all sorts of ways. We can hear about it from most of these are under the Hart-Scott reporting requirement. They're not $70+ million transactions. We can often hear about things from the state AG. We can hear about it from the press, and we look at the facts and decide whether or not there's a high enough concentration, and if the payers are telling us that they're worried that it will change the bargaining dynamics, that's something that we might have a concern about, and St. Luke's was a case we brought. The vertical transaction, where we might be interested with a hospital combining with a physician group, take the most extreme example, which is that you have a dominant hospital in an area, one with 80% market share, just to give a hypothetical, and it acquires every single cardiologist in the city, every single cardiologist within a 50-mile radius, say. Now you've got another hospital, it's got no cardiologists. It's got nobody to refer cardiology patients to it, and suddenly it's foreclosed, and it's not going to be able to compete to provide cardiac services, and that would allow the hospital, which may have an average of 80%, suddenly to have 100% in a particular market and exclude all competition. On the other hand, there are price-reducing effects from vertical transactions. A well-known effect is that you eliminate the double marginalization. Simply put, if I've got two people, they each need to make money. If I've got one person, they can figure out overall what the margin is. So there are benefits to vertical transactions, which is why neither federal agency has actually gone to court to challenge any vertical transaction in any industry. In decades, there have been many settlements in vertical transactions. I've worked on a number of them. An easy example of that is Pepsi and Coke both bought their bottlers downstream, and the FTC entered into consent decrees to deal with some of the problematic vertical aspects while allowing them to go through, because they did see the benefits to that. One of the things that we would look at is entry. You know, it's one thing to enter with a new hospital, right? It's time consuming, it's expensive. There can be certificate of need laws that make it particularly problematic. Your competitor can challenge whether or not there's a need for another hospital. You know, CON laws exist in the healthcare area, but, you know, in what other world does a competitor get to weigh in on whether or not you get to open a business? It's a bit unusual and a bit problematic for the antitrust enforcers. But that doesn't exist with respect to physician practices, and it may be quite easy for entry to occur. And we have seen examples where we've looked at physician combinations, particularly in urban areas, particularly in areas near lots of medical schools, where we say, you know what, the combination of these two physician practice groups won't be a problem because it would be easy for somebody to bring in new physicians of that particular type to be able to remedy any foreclosure concerns or to remedy any horizontal concerns. So it's very, very, very much a fact-specific issue depending on the type of physician group that you're talking about, depending on the geographic area, depending on hospitals and all sorts of things. So again, it's something we're alert to, but something we've not yet brought a case on.
Okay, yes, Joyce. And then
Jill Wexler with Pharmaceutical Executive Magazine. While nobody did specifically talk about the tax inversion incentives to pharmaceutical industry mergers, I'm just wondering if the financial benefits of such deals might be that you see evidence that they might be driving merger activity that otherwise wouldn't make sense or wouldn't be beneficial because of these financial incentives that they raise other problems, or conversely, that they're driving highly beneficial mergers involving smaller companies that can greatly benefit, that wouldn't take place without such financial incentives.
You know, I'm not in the boardrooms of these companies. I really can't comment on what's driving them to do the mergers. I mean, I think there's a lot of speculation that a number of these are pushed by inversion, but, you know, we haven't seen it. And ultimately, the reason, unless it's an anti-competitive reason, that a transaction comes about really is of no moment to us because we're looking at the effects of the transaction.
And I would say if a client came to me and said, we really want to do this because of the inversion benefits, I would say it's neither here nor there. We need to look at what the antitrust outcomes will be.
Bob Rohr, freelance. There's a trend I see emerging of providers, particularly larger ones, doing their own self-insurance, and more like on the Kaiser model, but going from the care into the insurance side of that. How is that going to affect the consumer? In some ways, I can see advantages of savings in some ways, and certainly clarity in that you know what you're buying when you buy an insurance policy. You're buying certain sets of providers and things. So how is that going to sort out?
I think if it gives consumers more choices, that's good. I don't think there's anything inherently wrong about that kind of a vertical integration, as long as it doesn't foreclose options in the way Debbie was just talking about. Insurance companies who can't get providers anymore because the providers are all doing their own insurance. That would have to be looked at separately. It might be just a change in the way that healthcare is delivered, and if that ultimately takes over, that's not necessarily bad for consumers as long as there's enough choice in the supply lines so that consumers have choices.
I saw a question down here.
Hi, I'm Sarah Carlin with Politico. In terms of pharmaceutical mergers, you talked a lot about divestitures, but how does FTC think about the future competition that's lost and the innovation that doesn't happen, or even in the generic drug space, the future competition that's lost in that space, especially as more and more consolidation occurs?
That's a good question. So we do look, and especially in the pharmaceutical area, we look at future competition, and that's because it's easier to look at in the pharmaceutical area because there's a very clear process for getting clearance. You have to go through the FDA pipeline, and so we are in regular contact with the FDA when we're looking at transactions to say, okay, who's filed for approval for this kind of product, and who's in the queue to develop a generic for this kind of product. And so our consents routinely talk about, if you were to search the word, FTC complaint and, future, you would see a lot of markets where we talk about divestitures occurring because it would eliminate competition that would happen in a couple of years. And so a huge number of our transactions look at that. To date, we have found that there are enough different companies that tend to innovate just generally that we have not worried about kind of a more global innovation concern, but it's something that we would be alert to if the number of pharmaceutical companies got smaller. What we found is that innovation comes from a number of places, small companies, large companies, medium companies, and there's still a huge amount of innovation. So we have tended to look at it sort of product by product to see what the pipeline looks like to determine whether or not we have particular problems, but we are alert to the larger issue as well.
From looking at complaints from government enforcement agencies, court decisions, and studies, we can get a pretty good idea of what is going on or what is happening in specific sectors. When we have this discussion, we're talking in general about mergers among doctors, hospitals, insurance companies, pharmaceutical companies. Do you have any sort of cross-cutting reflections about the larger changes and how they may or may not be considered in antitrust enforcement? In other words, is there anything besides just sector-specific analysis that you or others should consider?
For the most part, when people have come to bring their mergers to us, it is really much pretty specific to the facts of that merger. We do hear of some of these broader landscape issues like the need to move towards collaboration, the need to move towards risk-based contracting. We hear a lot about population health management, but the analysis that we use in every case is really pretty much driven by the guidelines and the questions we ask with respect to those things. Are they necessary? Are they sufficient? In other words, are these, the first question we ask, as Andrea mentioned, is this anti-competitive? You don't even get to, and George said the same thing, you don't even get to the efficiencies analysis until you've decided that there's a problem. So I think many, many, many transactions are probably driven by these broader ACA goals. We don't have to have that discussion if the transaction isn't problematic. And, there are hundreds of hospital mergers every year, and, we investigate, a handful, couple dozen that we'll actually look at, with some degree of significance beyond looking at the initial filing and realizing the hospitals are 200 miles apart and they don't compete. And then, it's an increasingly small funnel to where we're actually challenging them. It's in those handful that we actually have to have the conversation about, are the efficiencies merger specific? The very fact that we clear dozens and dozens of transactions and challenge only a handful suggests to me that to the extent that these broader things are going on, that we're doing a pretty good job of accommodating them, in the sense that, I shouldn't say that. That's not the way I meant to say this. It means that these broader things really aren't affecting most transactions in terms of the antitrust analysis that we look at, because a lot of them are getting cleared. So a lot of people are able to do the kinds of transactions they want without the antitrust problems, and it's really only a handful that are problematic. And in those, as I said, we've gone through the analysis and determined that they're still problematic.
Hi, Rich Daly with Healthcare Financial Management magazine. Just wanted to follow up a little bit more of a sort of zoomed-in question than Robert's. One of the issues that are frequently raised by hospitals looking at mergers and acquisitions, and an issue that comes up in accountable care organizations that you were talking about, is how to keep the patients that they are financially responsible for within their system of care. It's a big problem in ACOs, and it's a big problem outside with dealing with private payers who have these managed care systems, what have you, that when there's an incentive to improve the care for this patient, but the patient keeps leaving your system. Is there any approaches that you've found? You talked about other systems, payment systems that are effective, short of mergers and acquisitions. Are there any approaches that you could point to that are effective in terms of retaining those patients that providers should be looking to instead?
Yeah, it's a good question. It's really not something that the antitrust agencies look at. I mean, we're more focused on the question of, is it necessary for these two entities to combine so they can address the concern that you're worried about? And the question we would ask there is, are there any competitive aspects, and how does that balance against the possibility that if they combine, they would be able to do more risk-based contracting? And there we would talk to the insurers, among other places, to try to get a view on that. If the insurers say, yeah, that would be really helpful, we think that combining, they could reduce the costs because they would be able to better engage in risk-based contracting, and we think that that would be a good thing. That would be meaningful to us. If, on the other hand, the insurance companies say, look, I understand that may be the motivation, but all it's going to end up doing is increasing their price to us when they jointly negotiate, that would tend to concern us.
So we've talked a lot about the what goes into making these kinds of decisions. But George brought up an interesting question, or statement. He said that these deals or this activity can't be easily unwound. And I'm wondering if we could talk just a little bit about what kind of recourse there is if the promised benefits don't come to fruition, and maybe it appears that there is some detriment from the activity. Is there any kind of recourse? Is it possible to unbundle a merger? Has it ever been done? Are there penalties, sanctions? Is that...
So again, going to the question of, we're a law enforcement agency, so no sanctions, unless they violated a consent decree. If they've entered into a consent decree and violated it, we can get civil penalties. It's why we have a Hart-Scott-Rodino Act, which requires pre-notification of large transactions so that we can take a look at them and challenge them before the combination occurs. The best example in the hospital area of a combination that occurred was the Evanston-North Shore Highland transaction in the Chicago suburbs some years ago. The transaction was not challenged when it was additionally occurred. The prices went up dramatically. The FTC challenged it after the fact and got a remedy. The problem was that the companies had been so intertwined by then and had a really, I think, somewhat successful cardiac program that would have gotten sort of torn apart if the two hospitals had been split up. And so the remedy was that the hospitals would each separately negotiate if the payers wanted to. The payers, no payer took advantage of it, probably because it's a hard thing to figure out how it's really going to work at the end of the day. They both have the same CEO, and having clear division is challenging, and for whatever reason, the benefits of competition really didn't come about after that challenge, which is why we are so disappointed when we lose. A good example of a time we lost a hospital merger and ultimately were unable to achieve any remedy is with the Phoebe Putney-Palmyra case down in Georgia. There we did challenge the transaction when we first learned about it before it was closed. The district court decided that we were not entitled to relief because the transaction was immunized by the state action doctrine because one of the hospitals was basically a state-run, state-owned entity, and the state action doctrine says that if the state immunizes competition, the federal government can't do anything about it. We didn't think that the state action doctrine, in fact, applied, but the hospitals were allowed to merge. Went up to the 11th Circuit. The 11th Circuit said, wow, this is really anti-competitive. This is a problematic deal, but I think the state action doctrine applies. We then went to the Supreme Court, and the Supreme Court said in a 9-0 decision, no, the state action doctrine doesn't apply. The FTC absolutely has jurisdiction to look at this. But by then, the hospitals had merged. We tried to get a divestiture, but because of complicated CON laws, it was unclear. It did not appear that we were ever going to be able to separate the hospitals and have one of them sold to another party. So we couldn't get any remedy whatsoever. Highly problematic. I mean, really troubling to all of us at the commission who went through this, which is why we try so very hard to go after it the first time. We are technically allowed to go after a transaction at any time, even after it's closed, even if we had looked at it originally. I think the odds that we would go after a transaction that we'd investigated seriously and cleared it has not happened in recent times. I can't predict whether it would happen in the future. I do think that it's why we try so hard to get it right and why we're always going to err on the side of consumers as opposed to the promises that somebody has about why it's going to end up being a good transaction.
And something that Debbie just alluded to, and you had referenced in my statement, that once it's done, everybody makes their adjustments. You know, people who worked for one entity or the other are either brought into the new entity or they are let go and they go off to look for work elsewhere. Suppliers, customers make their adjustments. So you really don't have the contents of the two companies left in order to be able to make a clean break between them again. And it's often referred to with the metaphor of trying to unscramble eggs. You just can't, you know, there's one company there and it's too late. So that's why you have to do it before the merger happens.
So given this reality, do you have everything that you need? Do you have all of the legal tools that you need to be able to conduct a rigorous pre-approval process, or do you need anything from the policymakers? Anything more?
Look, I think the antitrust laws have served us very well for over 100 years. I think that we're able to look at transactions. It's a challenge in terms of, you know, I don't think any government agency will tell you it always has as many resources as like, but I think we do a very good job with what we have. We're able to look at a lot, and I think we're pretty confident that we're, you know, looking at the transactions that really need to be looked at, challenging the ones that are really problematic, and letting those that are not problematic go through as quickly and as efficiently as possible.
Great. So, okay, so let's wrap up here. Last question.
Thank you. Jad Shamsuddin, Congressional Quarterly. I just had a question regarding the certificate of need laws. How much does that factor into your analysis when you're blocking a merger, a state certificate of, like, whether you can effectively do it, and how much that's going to hamper future entrants, future competition?
So a couple of things to say on certificate of need laws. We look at it in virtually every transaction to see whether they exist, because it answers the question of whether or not entry is likely to occur. We often hear that entry may occur. You know, in the hospital merger situation, you know, if there's actually a hospital being built, that may convince us, and we have seen situations where there are new hospitals coming in, and so the snapshot that we're looking at this particular moment in time does not reflect what it's going to look like in a year, and we may decide that if you ignored the future entry, the transaction might be problematic, but given that other people are building hospitals, we're not concerned. On the other hand, if those plans of people are hampered by certificate of need laws, we may be more skeptical that the entry will in fact occur that a hospital says it wants to do because of that. So we'll look at that in the context of whether or not we think entry is likely. We have, when asked, we'll weigh in on certificate of need laws. We have an Office of Policy and Planning, and they are frequently invited by legislators to provide views on different legislation, whether it be COPA, Certificate of Public Advantage, or CON laws, or other legislation that affects healthcare providers, like the amount of certification that advanced practice registered nurses need, that sort of thing. There's a lot on our website because we make all of this public. Whenever a state asks us to weigh in on legislation, or if any of the federal agencies ask us to weigh in on particular things, there's a lot in the healthcare area that we've been asked to weigh in on. It's all up on our website. So we do look at these sorts of things pretty routinely.
Fantastic. So I would like you to do one last thing for me, and that is inside your packet you have a smaller piece of paper that's at the front. It's in a blue evaluation form. We would love to hear what you have to say, not just because we want to hear what you have to say, but we're going to be doing these kinds of events once every couple of months, and they're for you. We want to hit the subjects that you want to hit. We want to bring in the speakers you would like to hear from. So please tell us very specifically if you have a thought about what subject is pressing, you want to hear more about it, what speaker. So if you could take a minute and fill out the evaluation, that would be great. I'd like to thank you all for getting up very early on a Tuesday morning. And again, I'd like to thank Health Affairs for their partnership, and also the JKTG Foundation for its support of these briefings.